Hello and welcome to On the Table. We're broadcasting on RTM Click and MyTV's Berita RTM channel 123, which is also live streaming on Facebook. I'm your host, Otto Othman. Good evening and thank you for joining us as we explore the various drivers of medical inflation in Malaysia and potential strategies for mitigating these while ensuring that essential services remain within our reach. Now, joining us today is Professor Emeritus Dr. Syed Muhammad Al-Junaid, Professor of Health Economics, Policy and Management from IMU University. Now, Prof, thank you so much for coming to the studio. Now, without further ado, Prof, let's start off with the first question. What are your primary drivers of medical inflation in Malaysia and how do they compare to global trends?
Yeah, medical inflation is something that we have been talking about, not only now, but we have been talking about it for a number of years. Why healthcare costs goes up. It was stated that in the figures that we got from Malaysia at the moment is about 12.6%. And it's estimated that next year, it might go up higher than that, maybe 15%. But having said that, we should also look at the international trend. You look at countries, less developed countries or developing countries around the region, they have somehow higher inflation rate, medical inflation than Malaysia. For example, countries like Indonesia, Philippines, Vietnam, they are more than 12%. I think Vietnam, it was estimated that as high as 20% this year.
Wow.
But if you look at the other countries, more developed countries, especially OECD countries, their inflation rate is much lower. It's around 9.7%. Oh. So, of course, we are on the increasing trend. But what is the cost of this medical inflation? Yeah. First and foremost, we must know that it's quite difficult to stop healthcare costs from going up. It will go up from time to time, but what we can do, if we take a lot of preventive measures, for example, we would be able to reduce the rate of increase. The reasons why the healthcare cost goes up can be divided into two parts if you're looking from the economic perspective. The demand side and also the supply side. When we talk about the demand, we are referring to the population. Our population now have got a lot of the prevalence for chronic non-communicable diseases, for example, diabetes. It affects about 22% of our population. And hypertension, for example, nearly about more than 1/3 of our population is suffering from that. And then the prevalence of cancers is also going up. And then chronic respiratory diseases, which are related to, most of it are related to the unhealthy behavior, like smoking, for example, vaping, for example. So all this actually, one of the reasons why the healthcare cost goes up. So a patient admitted to the hospital nowadays, it's very rare for this patient to only have a single diagnosis. For example, a patient admitted for, say, a road traffic injury, maybe the patient have got a fracture of femur, for example. But this patient, normally, if they are more than 40 years of age, they would also have hypertension, diabetes. So treatment of, say, a fracture of femur would be more costly. We have to take into account of the other chronic diseases that the patient have. So that's one of the important areas that we must understand. Increasing prevalence of chronic non-communicable disease is one of the cost driver. Apart from that, our population also, most of our population, a big chunk of them are actually practicing unhealthy lifestyle. For example, lack of exercise, smoking, for example, taking high-fat diet, high-salt diet, for example, as well as a lot of sugar. All this actually leads to these chronic diseases, and all these are actually factors that influence the healthcare costs. If you look at the demand side, this is demand. We look at the supply side. We are talking about hospital, doctors, as well as private insurance. They also contribute quite a lot in the risk in healthcare costs or the medical inflation. For example, treatment of diseases now. We have a new technology. We have new drugs, new intervention, new modes of investigations. All these equipments are all very costly. So these actually contribute significantly. Apart from that, there are also issues related to the purchasers of the healthcare services, like private insurance, for example, they contribute quite a lot as well in terms of the raise in healthcare costs, because it relates to how we pay the hospitals and also the doctors. If we are using fee for service, for example, where we pay using atomized billing, studies have shown that if we pay using this method, it is more likely that the cost is very difficult to control. It will go up because the likelihood of hospitals and doctors might introduce new treatment or treatment that may not be necessary for the patient, which in economic term we call it supply-induced demand. It's very difficult to control if actually we use this fee-for-service method of payment. That's why one of the proposals by Negara is to change the way that we pay the hospitals and also the doctors. So both sides, the demand side and the supply side, contributes quite significantly to raise the healthcare costs and contributes to the medical inflation in our country.
Which is why it's very intricate and kind of difficult. It takes time to actually adjust to this new mechanism. But then again, Prof, how does this make this healthcare accessible to Malaysians?
Well, basically, we were quite fortunate because we have a public health system run by the government, and the charges in the government facilities are very, very low. In fact, if you go to health centers, you don't have to pay anything, and you only pay RM1 if you need to for the outpatient care. But this is the current situation. And I think this actually creates a lot of problems as well, because with this amount of charges that we put up for the public, they can access the facility, but we will have problems to sustain this in long term. And remember, our healthcare expenditure, the amount that we spend for healthcare in this country is around 4.5% of GDP. This is very low, which means that the resources that goes to Ministry of Health to manage the hospitals, the health centers and all that is very limited. Other countries, for example, if you look at OECD countries, they spend nearly about 11 to 12% of GDP, which is 3 times higher than what we are spending for. So they have a much broader financing mechanism and resources for them to manage healthcare services. So it's going to be difficult. We promised the population that we provide what we call universal health coverage. I think this is still ongoing, but the universal health coverage is difficult to sustain and to maintain if we don't have enough resources. Universal health coverage means that the country will be able to provide access to services to all patients, to all members or all the citizens in the country, irrespective of their ability to pay, irrespective of where they are located, irrespective of what diseases that they suffer from. The healthcare services under universal health coverage, the determination, the factor that influence the use of the services is only the need of healthcare, which means that those who have higher needs of health services, they must given better access to the services than those who have got lesser needs, for example, those who are healthy, for example. So universal health coverage, which Malaysia claimed that we have achieved it in the 80s, need to be relooked because it's very difficult to maintain with the limited resources that we have today.
Mm-hmm. Well, there are a lot of things that you just mentioned early on, from supply to demand to universal healthcare. It's still in the process, and there are a lot of factors. Now, I would like to ask as well, can you explain the relationship between the medical claims, inflation, and premium adjustments in health insurance?
So recently, there was a debate regarding there was an announcement that the private health insurance operators plan to increase the premium to as high as between 40 to 70%. Why this actually raised in this premium? I mean, the reasons given by them by the operators is because they have to pay a lot of resources to actually provide for the services which are being used by those who actually in the policy, these people who actually own the policy or pays for the policy, the enrollees of the system. But having said that, we must remember that the way that our health insurance, private health insurance operates in this country is also different from other countries. For example, if you look at the European countries, especially Netherlands, Germany, for example, and France, the rate of increase in their premium is very minimum. Its maximum is around 5%. What's the difference? The difference is because in this country, in European countries and also in OECD, most of the OECD countries, the insurance, private insurance over there operates on what we call a community rating. Community ratings means you actually provide the services or the products of the insurance And you cannot differentiate between, you cannot actually discriminate between different ages and also different experience of using the services. This is illegal in the European region. So what we call community rating. Here in Malaysia, our private insurance operate on what we call risk rating. Risk rating means if you have a higher risk, for example, if you are the patient who is older age group, those who have history of using the services or claims from the insurance providers before, they will have to pay higher risk because they have to pay higher premium because the risk is high. So because we allow that risk rating to be used in this country, then the private insurance will increase their premium once the patients or the people have actually start to claim from their operators, the insurance agencies that they have bought the policy. So this is the difference. If we move or we ask the insurance agency or by law, for example, not to actually calculate the risk based on risk rating and move toward community rating, most likely that we will be able to reduce the likelihood or the increase in the premium. But of course, this needs to be regulated. You need to have a change in the law, for example, like most of the OECD countries have done. Australia, for example, the rate of increase of insurance premium is just about 3%. So why is it? Because again, they don't allow risk rating to be used as a mechanism to calculate the premium for the private insurance.
I see. Now, having said that, Prof, Bank Negara Malaysia has stepped up to help Malaysians hit the higher health insurance premiums. How effective do you believe the cap on premium increases at 10% will be alleviating financial burdens on policyholders?
Yeah. I mean, we should be thankful to Bank Negara also for taking these interim measures and trying to actually make a maximum cap of 10% over a period of 3 years. But personally, to me, as a researcher in health financing, I find that this is not enough. It will only help to actually mitigate these issues over a period of 3 years, for example. The same problem will happen again after 3 years. I think a 10% cap is just will not be able to solve all the problem. You need to go to the root cause of this, the way that the insurance premium is calculated, and the way that we want to control the escalation of costs in the private hospital and also the services provided by this hospital. This needs to be done. And of course, one of the interim measures that was mentioned by Bank Negara is also to introduce diagnosis-related group, which is the way that the services are going to be reimbursed based on a package payment rather than using the fee-for-service method, which I just mentioned earlier on. This is a good move, but of course, it takes time for us to reorganize this, and I'm sure in long term, it will benefit the country.
Do you think, Professor, out of context here, do you think it's a timely process right now, seeing that we're going to move towards a more aging community as well here in Malaysia? Do you think it's timely enough, or do you need more time to actually move up the scale a bit?
Aging population is one of the factors that increase the healthcare costs and then influence or contribute to the medical inflation. But if you are using private insurance as a source of funding for this group, it will not be feasible because normally the private insurance will not cover those who are the elderly because the elderly needs a lot more services. And if they were to cover also, the premium will be unaffordable for this group of population. So to me, if you want to solve this problem in long term, we need to find an alternative. Currently, private insurance is subscribed around 22% of the population, about 8 million people. But what about the other 80% of the population, who are not actually covered by any form of health financing scheme? So I think the best solution in the future, the government should actually look at introducing another alternative source of funding, which is social health insurance, or what we call national health insurance. This is a health insurance which is actually run by the government and managed by the government and use community rating rather than risk rating. So by using that, you will be able to cover most of the population at a much lower cost, much lower premium compared to the private insurance that is running the show at the moment.
Well, thank you very much, Professor, for enlightening us on that particular topic as well. We're going to go for a little short break with our professor here, Professor Emeritus Dr. Syed Muhammad Al-Junaid, Professor of Health Economics, Policy and Management at IMU University. And we'll be right back to dig deeper into this health insurance policies as well. So stick around.
Hi, I'm Simon Sun, the CEO of Huawei Malaysia. Cutting-edge innovation and talent cultivation are the backbone of Huawei's success internationally. We walk the talk and we believe in giving back wherever we operate. Our talent who work with us are required to constantly reskill, upskill, and cross-skill with our learning platform and compulsory examinations. We also have a CSR initiatives that include Huawei's ICT academies in 40 public and private institutions of higher learning in Malaysia that train trainers and students in the realm of ICT. We aim to help this nation in its quest to become a digital powerhouse of ASEAN. We look forward to Malaysia's chairmanship of ASEAN and working alongside the nation in its digital and technological endeavors.
Thank you very much for joining us here today. And we're talking to Professor Emeritus Dr. Syed Muhammad Al-Junaid, Professor of Health Economics, Policy and Management from IMU University. And we're talking about exploring the various drivers, of course, of medical inflation in Malaysia and the potential strategies. Now, we left off whereby we understood that a lot of things are, it takes a lot of things to actually build, or when it comes to premium increases and all that, from supply to demand to even the policies that we make. Now, my next question here, Professor, is what do you think will happen if premium changes are spread out over 3 years for those affected?
Yeah, I think for short term, I think this is a good, intervention by the government. At least we have a period of 3 years where people will be able to reorganize themselves. The insurance operators can also be taking steps to address the internal issues in order to manage this. But as I mentioned earlier on, 10% over a period of 3 years, it will be frozen to that particular level of increase. It will actually solve only short-term measures to actually solve this issue. It will give some breathing space for the insurance agencies and also for the population, those who have purchased the insurance before. I think this is a good move, but we need to take further action, more concrete action, more long-term measures if we want to actually ensure that people who actually subscribe to private insurance would be able to use their private insurance properly whenever they need healthcare services, and they will not be burdened by the high level of premium that they have to pay. Many of them will not be able to pay for it. They won't be affordable not affordable to them, especially those who are in the M40 group who have purchased this private insurance as well. The T20 should be okay, maybe they have enough resources. But M40, we do not know how many percent of the M40 have already acquired some form of private insurance. So long-term measures need to be carried out beyond these 3 years.
Understood, Prof. Now, in your opinion, what systemic reforms are necessary to address the root causes of rising medical costs beyond 2026?
Yeah, I think we have to look again at both sides, the demand and the supply side. From the demand side, I think as a public health physician, we would have to increase our health education to the population to make sure that population are much healthier. They'll take steps to actually improve their health status, reduce intake of, say, for example, salt intake, sugar, for example. And if they are already having a chronic non-communicables now, they should actually take a continuous treatment from their doctors that they are seeing, and don't take treatment that are actually not proven to be effective, for example. We see a lot of advertisement in the Facebook and all that. These are non-proven treatment, and sometimes we waste a lot of money by using this unproven treatment, ineffective treatment. So that is from the demand side. We need to make sure that our population are healthy. This will, in long term, it will help to reduce the overall cost. That's very important aspect that we need to do that. From the Supply side, this is very important. We have to have a long-term measures to actually ensure that the healthcare costs and healthcare and charges in the private hospitals are transparent, and then mechanism must be put in place so that people who goes to seek healthcare, they will be able to know how much they are going to be charged in total. So these are the transparency that we need in the total charges. At the moment, if you are admitted to the private hospital, you wouldn't know how much you're going to be charged until you check out or you are about to be discharged.
Yes.
So it's very unpredictable. If you have a package payment, like the RGs, for example, then the mechanism will be put in place where people will be able to know how much they're going to be charged for one package of treatment. So that will actually make things more transparent, and it will also encourage hospital to provide efficient services that in long term will reduce the likelihood of having high inflation for the medical services. So that's a very important aspect that we need to look into.
Now, Prof, how can stakeholders collaborate to improve the transparency in medical billing practices within the private healthcare services?
Yeah, basically it needs some form of regulation from the government to make sure that the package payment are being implemented. For example, at the moment, under the Healthcare Facilities, Private Facilities Act, the itemized billing was actually required. I think this needs to be changed. I think our Prime Minister has said that they plan to actually amend this regulation to implement package payment rather than using itemized billing, for example. I think that's a very important aspect. Without regulation, it's very difficult to actually do this. Mr. Otto, if you look at the way that the hospitals are being paid, there are two types of payment. The fee for service is called retrospective payment. Retrospective payment means the total payment is only decided at the end of the stay. Okay, this is where itemized billing comes in and all that. And once you go for the itemized billing, it is very difficult for us to control anything or to actually track anything, because every item is written down and there is a cost to it. And we are not sure whether these items are going to be is necessary or not for the patient. And if we have a party that want to look into this, it's very complicated. If you look at the prospective payment, for example, the RGs or for the primary care services, we use capitation. These are only one item at the end of the day. It's very much easier to actually track the cost, and then we'll be able to make it really transparent for people to actually understand this. So we need all this. The regulation and the policy must be put in place. And I think if we have that, it is much easier for people to understand what they are going to go through when they need healthcare services in the private, even the public facilities as well.
Now, Prof, moving on, what roles does digitalization play in managing healthcare costs and also improving patient outcomes?
It is not direct, but it will be a very good factors, digitalization, to make sure that whatever that we are doing we are recording is recorded properly. For example, under the digitalization, we have electronic medical records, for example. So patients who get treatment from these hospitals or these facilities, the information is well stored. And if the patients were to go from one facility to another facilities, if there is a mechanism for sharing of information, then it will be much better. You don't have to repeat the same treatment or the same investigation that has been done. So digitalization plays quite important factor in trying to make the system more transparent in the first place, and also you use the data properly in order to track the cases and also to provide good quality services. So tracking of quality of care is very much easier if we use the digital mechanism like electronic medical records, for example. So they are very useful. I think this is quite timely, and we should actually move toward that. We are actually lagging behind compared to many other countries in the world, actually.
Well, with that also, Prof, how should policyholders actually respond to recent changes announced by BNM regarding their health insurance policy?
Yeah, actually, I mentioned earlier in another discussion before that the private insurance and enrollees, for example, they are quite stuck at the time before Bank Negara come in with the solution. Now there is some light at the end of the tunnel. There is a recommendation by Bank Negara that those who are more than the age of 60, they will not be, there is a freeze in terms of increase in the premium. That's a good sort of action, but of course it's only for 1 year. After 1 year, we have to wait what will happen to that. For those who already, there was also statement by Bank Negara that for those who have already dropped off their private insurance, they can actually enroll back without paying the penalty. I think that is a good action by the Bank Negara. At least people who have actually stopped their private insurance because of the increase in the or potential increase in the premium, they will be able to hop back into the system and will be able to use that. But having said that, I think the people who are already or plan to buy the private insurance, you have to be very careful and you read the detail, especially the small print. What is covered and what is not covered. One of the important things that we found that a lot of rejection of the private insurance is because people, when they buy the private insurance, they do not declare what are their current status. Because remember, we are using risk rating, you know. So if you have diabetes, hypertension, and you buy the private insurance, you don't declare it. And later on, if you have any complication related to diabetes, for example, related to hypertension, for example, you have stroke, and it turns out that that stroke is related to due to hypertension, and it will not be covered by your by the private insurance scheme that you have purchased. So be very careful about it. Look at the product carefully. What is covered, what is not covered. Then only you purchase it. Otherwise, there's no point hiding your risk, for example, because the way that the insurance premium calculated is in this country is based on risk rating. So read the details before you decide if you want to purchase the private insurance or not.
Now, Professor, one last question over here. What trends do you foresee in Malaysian healthcare system concerning medical inflation over the next 5 years?
Yeah.
What do you foresee?
Yeah, I think the healthcare cost is going to go up, but if we take affirmative steps by all parties involved, we would be able to at least reduce the rate of increase. But we need to do a lot more proper reform in the health system. I really want the government to actually look at this and provide a real reform in our health system, especially to think about introducing the National Health Financing Scheme that provide a sort of alternative for people who are not able to purchase private insurance and are not able to depend on private insurance as their source of financing for their healthcare needs. So that's what I hope to happen in the next 4 or 5 years. Yeah.
All right, thank you so much, Professor, for your insights and details. So let us learn a few things about what we learned today, especially when it comes to premiums and seeing that how Malaysia's governing body is managing all this particular like supply and demand, and making sure that your health is on point is also a main factor why our premium is particularly at this particular stage, and make sure that you read the fine print of your policies as well. All right. So with that, I would just like to say thank you very much to our guest for today. I would just like to say once again to our Professor, Emeritus Dr. Syed Muhammad Al-Junaid, Professor of Health, Economics, Policy and Management in IMU University. Thank you so much, Professor. And with that, that's all the time that we have for today on the table this evening. And we've been speaking to our favorite professor here. And with that, a repeat of this episode's broadcast can be viewed again at the same time tomorrow and subsequent days on RTM Click and MyTV's Berita RTM channel. So till next Thursday, we'll discuss another topic of interest as well. I'm Otto Othman, signing off.